Medical abortion is defined as termination of pregnancy using medications up to 10 weeks, which is 70 days of gestation. And this is the 70 days are counted from day one after the last cycle. There are some contraindications to medical abortions. The contraindications include confirmed or suspected ectopic pregnancy. Um, if we expect ectopic pregnancy, it has to be terminated, of course, but we don't use medical abortion for the termination of ectopic pregnancy. Females using IUD, there is increased risk of ectopic pregnancy in females using IUD. So if ectopic pregnancy is ruled out, then we have to remove the IUD before abortion. Hemorrhage or using anticoagulants, we need to monitor carefully. So it's a contraindication, but we still can use the medical abortion, but we have to monitor carefully if performing medical abortion. And here we have to monitor for the bleeding because the female will experience more bleeding. It's contraindicated in patients with anemia because of the it's associated with more bleeding. If the patient is not sure of the decision, because this is a reversible process. If the baby is lost, the baby is lost. We cannot do anything about that. And hypersensitivity to medications. So as you can tell, some of these are considered um, like relative, or they are not really absolute contraindications. Some of them, like for example anemia, well, you still can perform medical abortion, but you have to keep in mind that there is more bleeding. Also hemorrhage or taking anticoagulant, you have to be mindful that the female will experience more bleeding if she's taking an anticoagulant, and we have to just monitor for that. But anyway, these are the contraindications to medical abortion. So how is medical abortion different from surgical abortion? Um, so here we have a table of comparison. Medical abortion is more than 95% effective. Surgical is more effective and it's 99% effective. Medical abortion is more private because it can be done at home. Surgical abortion has to be done in the office, so it is less private. Medical abortion requires 2 to 3 visits to the physician, while the surgical abortion can be done in one visit. Medical abortion requires no anesthesia, while the surgical one may require anesthesia. Medical abortions Medical abortion can take days to weeks to be completed. Surgical abortion can be completed in 5 to 10 minutes. Medical abortion is painful. Surgical abortion has less or no pain. And in medical abortion, we may still need to do surgery after the medical abortion to complete the abortion. So sometimes it will be incomplete medical abortion, and we have to perform a surgery to remove the remaining tissue from the uterus. Medications and regimens, we have 3 medications that we use. We have mifepristone, we have misoprostol, and we have methotrexate. They can be used alone, but less effective, so we commonly use them in combination. Here are the 3 regimens we use. I know the slide may look slightly different than what you have in the book. I just reorganized it a little bit, to make it a little bit easier to follow, but it's exactly the same thing you have in the book. So mifepristone is an anti-progesterone medication. It causes endometrial degeneration, cervical dilation, and reduce the level of the human chorionic gonadotropin, which is the hormone that's essential to maintain pregnancy. This leads to termination of the pregnancy. So it's used in combination with misoprostol. On day one, we give the patient 1 tablet of mifepristone orally, just 1 tablet, and then day 2 and day 3. On day 2 and on day 3, the patient will receive misoprostol in a dose of 800 microgram. These 800 microgram, they come as 4 tablets of 200 microgram each, and the patient will put 2 tablets on each side of the cheek, 2 on the left, 2 on the right. So the patient will use 800 microgram of misoprostol buccally on day 2 and 800 microgram of misoprostol buccally on day 3. And the patient will let them dissolve, and she will swallow the remaining. Termination happens within 3.3 days. This means that the termination will happen shortly after the second dose of misoprostol. Misoprostol can be used as monotherapy. As you all know, misoprostol is a prostaglandin analog that induces uterine contractions, and that's how it induces abortion. So the dose of misoprostol is 800 microgram, which is again 4 times 200 microgram tablets, either vaginally or sublingually. So when it's used by itself, it's used vaginally or sublingually. If there is no bleeding or passage of tissue after 3 to 24 hours, we give 1 dose and we wait for 3 to 24 hours. If the first 24 hours after the misoprostol dose, the female does not experience any bleeding and doesn't see any tissue coming out of the vagina and the uterus, then the female can take an additional dose. The termination is 6.6 hours. So after the dose, within about 6 hours, the female should experience bleeding and passage of tissue. However, the bleeding may continue for 8 days. The last regimen is the methotrexate-based regimen. So methotrexate is a drug that blocks the folate synthesis, as you all know, and this impairs the division and the repair of the embryonic cells, and this leads to abortion. On day one, the female will take 50 milligram orally or IM of methotrexate, and then on day 4 and 5 or 6, the female will take misoprostol 800 microgram, same thing, 4 tablets of the 200 microgram, and the female will use them vaginally. Um, if after the second dose of misoprostol for 24 hours, after 24 hours of the misoprostol dose, there is no bleeding or passage of tissue, the female can use an additional dose of misoprostol. We said the same thing before. So we give 2 doses of misoprostol. Is 24 If after 24 hours of the second dose there is no bleeding or passage of tissue, the female can take another dose of misoprostol. And this regimen is not used in breastfeeding. And the regimen that's methotrexate based regimen, um, the termination happens in 7.1 days, and um, this is a delayed onset compared to the other regimen. A follow-up appointment as early as 3 days, but commonly between day 7 and day 14 is required to confirm termination. So the female will take the medications at home, experience the bleeding at home, and then the female will need to make an appointment with the physician. It can be done 3 days after taking the drug or 7 to 14 days. This is to confirm that the pregnancy is terminated. How will the physician confirm the termination? This can be done by the symptoms. When the female has heavy bleeding, severe cramping, and cessation of the pregnancy symptoms. So that's what the physician will check to make sure that the pregnancy was terminated just by checking the symptoms. The physician also can do an ultrasound to confirm that the pregnancy was terminated, and the physician can do a test for the human chorionic gonadotropin level. The level of the human chorionic gonadotropin starts to go down within 24 hours. However, it reaches baseline in 7 to 14 days. So when the female goes to the physician, for example, 7 days after taking the pills, the physician will use these measures to confirm. So make sure that the female had heavy bleeding and severe cramping, which means that there was induced labor kind of thing. Also, they can use ultrasound and they can check for the human chorionic gonadotropin level. It should be lower level than the pregnancy level. Um, there are no fertility complications for medical abortion. So medical abortion should not have any problem in the future pregnancy. It doesn't cause miscarriage. It doesn't cause birth defects, preterm or low birth weight delivery, or mental health conditions. So it doesn't affect any future pregnancy, and it should not, and also has no psychological complications on the lady, such as an anxiety, stress, or PTSD. Medical abortion is associated with several complications, and on this slide and the next few slides, we will discuss these complications. And the first one we'll discuss is bleeding. And with medical abortion, bleeding is expected, and the female should be ready for the bleeding. And the bleeding usually starts within few hours of misoprostol administration, and the female may notice the presence of clots and tissue in the blood. The bleeding should be managed using thick pads, and the woman should be advised to not use tampons. The lady should seek medical attention if bleeding is extensive. So bleeding is expected, yes, but if the bleeding is extensive, then the lady will need to consult the physician. When should the lady consult the physician? When should the lady consider the bleeding to be extensive? That's when the lady or the blood is soaking 2 or more pads per hour, and we're using here thick pads. So if the blood soaks 2 or more pads per hour for 2 consecutive hours, or 1 pad per hour for 10 consecutive hours, that's when the bleeding is considered extensive and the lady should seek medical attention. Females who undergo medical abortion commonly experience pain and cramping. The pain and cramping start 2 to 4 hours after misoprostol administration, and as needed NSAIDs are used as the first choice to manage the pain and cramping, especially naproxen and ibuprofen. Even though we know that NSAIDs inhibit prostaglandin production, they are still the drugs of first choice for managing pain and cramping after medical abortion. If the NSAIDs give inadequate response, then we can use a combination of opioids plus acetaminophen, something like Tylenol number 3, can be used as needed to control the pain and the cramping. Please take a note that young females and females who never give birth before, like nulliparous women, they have higher analgesic needs, so they need to take more analgesic to control the pain and the cramping. If the female has severe pain that is not controlled by analgesics, this pain may indicate an infection, and in this case, the female should seek medical attention immediately. Misoprostol, as you all know, is a prostaglandin analog, and that's why misoprostol is associated with prostaglandin-induced adverse reactions. And these adverse reactions are mainly self-limiting within few hours. These prostaglandin-induced adverse reactions include nausea and vomiting, and these can be managed using dimenhydrinate, doxylamine pyridoxine, or ondansetron. The female also may experience diarrhea because of the misoprostol, and this can be managed using loperamide. The female may also experience other prostaglandin-induced adverse reactions such as headache, dizziness, fever, chills, etc. And usually these symptoms are self-limiting within a few hours, as we mentioned earlier. So the female should be advised to seek medical attention if these symptoms persist for more than 24 hours. Females who undergo medical abortion may also experience incomplete abortion. And on a previous slide, we discussed how we can confirm whether abortion was complete or not. Symptoms of incomplete abortion include unexpected heavy bleeding and cramping, or the absence of bleeding altogether following the administration of misoprostol. And as we mentioned before, bleeding is expected. So if there is no bleeding after the administration of misoprostol, this may suggest or may indicate incomplete abortion. Whenever incomplete abortion is confirmed, there are different approaches that we can use. The first approach is what we call watchful waiting. And in this case, we will just wait for the embryonic tissue to be expelled. The second approach is surgical approach. And surgical approach is specifically required. That's when they aspirate all the tissue or all the remaining tissue from the uterus. And this is especially required if the female has severe bleeding or if we suspect an infection after the medical abortion. In this case, if there is incomplete abortion associated with severe bleeding or incomplete abortion with infection, then the surgical intervention is required to remove all the remaining tissue. The third approach is the medical approach by the administration of an additional dose of misoprostol alone or in combination with mifepristone to facilitate tissue expulsion. One final note here, sometimes pregnant females experience what we call fetal demise. This is when the embryo dies in the uterus. So there is no plan for medical abortion or anything like that. The lady is pregnant and the baby dies in the uterus. In this case, a combination of misoprostol plus mifepristone is used to expel the tissue in case of intrauterine fetal demise. The next complication of medical abortion is teratogenicity. And both misoprostol and methotrexate are known teratogen. Misoprostol is associated with limb abnormalities and the neurological abnormalities that affect muscle control, and methotrexate is associated with growth deficiencies. On the other side, mifepristone doesn't appear to have teratogenic effect. However, some references suggest that all three agents are teratogenic. Someone may say, just a second, we are doing abortion, so we are getting rid of the embryo. Why are we worried about teratogenic effect? This is for two reasons. The first, there is a possibility that abortion fails, and this means that the embryo will remain, and this embryo got exposed to potentially teratogenic drugs. In this case, we have to complete the abortion using surgical intervention by removing all the tissue. The second reason why we worry about teratogenicity, even though we are talking about medical abortion, is because of the possibility that the female can get pregnant again shortly after taking these teratogenic medications. And that's why it is important to counsel the female who will undergo medical abortion to avoid pregnancy during the menstrual cycle immediately following abortion. The next complication of medical abortion is pelvic infections. And generally speaking, pelvic infections following medical abortion are rare, and the symptoms include abdominal or pelvic pain, uterine tenderness, foul-smelling vaginal or cervical discharge, prolonged bleeding or spotting, or fever or chills. And it's very important to educate the female to seek medical attention immediately if she experiences any of these signs and symptoms at any time during the 2 weeks following medical abortion. So this is the time frame for when we are concerned about pelvic infections within 2 weeks following medical abortion. Management, we can try to reduce the risk of uh, pelvic infections by using buccal misoprostol instead of vaginal misoprostol because this was found to reduce the risk of pelvic infections. If the female develops mild pelvic infection, we can use oral broad spectrum antibiotic for the treatment. If the infection is severe or the infection does not respond to oral therapy, then the female should be hospitalized and receive intravenous antibiotics. And at that time, we should also assess to see if there is any retained tissue in the uterus. And if we find that there is retained tissue, then this tissue has to be surgically removed. Now, we have a question. Why don't we use the antibiotic prophylactically in this case? Why do we wait until there is an infection? If we know that infections may happen, why don't we give the antibiotic to prevent the infection? Well, first of all, routine use of antibiotics reduce the incidence of infections. Yes, that is right. So if we start the antibiotic, regardless whether there's infection or no, this will reduce the incidence of infections. But there are a few points to keep in mind. First, infections following medical abortion are rare. So why do we need to treat all women who will go for medical abortion with an antibiotic routinely or prophylactically, even though the infections are rare? So this is number one, why we don't use antibiotics routinely. Number two, routine use of the antibiotics is associated with poor adherence and side effects. So that's why we reserve the antibiotics until they are needed. So antibiotics are used when needed, when there's infection, rather than being used prophylactically. The last complication of medical abortion we'll discuss is toxic shock syndrome. And toxic shock syndrome is very rare following medical abortion. Okay, if it's very rare, why are we discussing it? For two reasons. First, it can be fatal. Second, it happens suddenly, and that's why we need to monitor for it. Toxic shock syndrome is caused by bacteria, and the causative agents in females who undergo medical abortion are Clostridium sordelii and the group A streptococci. In other settings than abortion, it's caused by Streptococcus pyogenes or Staph aureus. Now, let's talk briefly about this Clostridium sordelii. This is a gram-positive bacteria, and in some females, but not many, in some females, Clostridium sordelii is a component of the vaginal flora. And during medical abortion, it actually may enter into the bloodstream during medical abortion, during childbirth, during miscarriage, during surgical abortion. So it can cause infection and cause toxic shock syndrome. The problem with Clostridium sordelii is it produces toxin, and this toxin causes hypotension, and it can progress to cardiovascular collapse, as we'll see in the symptoms. The symptoms of toxic shock syndrome, some symptoms are not characteristic. They can happen with other things such as nausea, vomiting, diarrhea, and abdominal pain. And these symptoms can also be adverse reactions of prostaglandin like misoprostol. And there are some symptoms that are characteristic symptoms. And these symptoms include little or no fever, tachycardia, hypotension, edema, leukocytosis, increased heart rate, increase in the hemoglobin and the hematocrit, and rapid deterioration of the patient's condition. And that's why we said that it can happen suddenly. And that's why we needed to monitor for it. In terms of management, the management is mainly supportive. So if there's fever, we can use acetaminophen or ibuprofen. We also need to use empiric antibiotic therapy. And typically we use a combination of vancomycin plus piperacillin tazobactam. This is usually the combination of antibiotics that we use empirically in females who get toxic shock syndrome. In some severe cases, though, surgical intervention may be required. So we either have to do surgical debridement of the uterine tissue, and even in severe cases, the female may have to have hysterectomy. Now, when should the female start the birth control after medical abortion? So generally, fertility resumes in 8 days and ovulation in 21 days. Contraception is important because of the teratogenic effect of the medications we use to induce abortion. So that's another concern. We said teratogenic effect. Teratogenic effect can of the misoprostol and methotrexate. This teratogenic effect may affect the embryo if the medical abortion was not successful. And also it may affect the subsequent pregnancy because subsequent pregnancy can happen shortly after the medical abortion. So the drug is still in the body, and this can cause also exposure to the teratogenic medications. We need to start hormonal contraceptives except IUD or IUS the day of the misoprostol use. The day of misoprostol use. IUD and IUS, they will be inserted once abortion is complete.